my video and put myself on mute.
Thank you so much, Roseanne, for that lovely, lovely introduction. I feel very honoured there. And thank you, everybody, for joining us this evening to listen to me talk about celiac disease. I sort of did a funny squinty face because when Roseanne says 40 minutes, I think I could speak about celiac disease for a full day. So do apologise if it's too much information at any time. And of course, with the questions and answers, if there's something in particular that I've mentioned that didn't make sense, or something that you'd just like me to clarify or anything like that, just pop it in the Q&A and we can cover that. Hopefully there'll be a bit of time at the end if I don't ramble on too much. So I'm going to start this presentation. So really it was just a full overview of celiac disease right from the start through to how we treat that as in dietetics to help patients. And hopefully on that way through, I'll talk about a few different areas that are a little bit contentious and a few sort of new and sort of more exciting areas that are changing. And certainly since I became a dietitian have changed a lot. So hopefully it'll be interesting. I've also got a case study at the end, so if you are interested to stay on for that, you're very welcome, and it'll just be thinking about sort of clinically in practice how I might think about a challenging sort of history, and how I might sort of go about trying to get a diagnosis for a patient. So celiac disease, where did it start? So, and do forgive me because I will definitely not pronounce these words right. So it was first described in actually 100 AD by a Greek medic who used the term abdominal diathesis. And then when his works were published in Latin, the Greek word for abdominal, and if I say this right, I'm doing well, I think it's Coeliac, was then transcribed to what meant celiac, and that's where this name has come from. But really it was the work of Dutch paediatrician Willem Dick, who was conducting trials with gluten exclusion during World War II in Holland, and actually found that because of rationing in the war, and actually some children were admitted to hospital with when sort of gluten wasn't available due to rationing, and then when it was available, and he could really see the difference between sort of the symptoms of these patients, and that's really where it first sort of was recognised and sort of given this term as a lifelong gluten-related disorder. So a celiac disease, how prevalent is it? You might all either have celiac disease or know somebody or have treated somebody with celiac disease, but we think about 1 in 100 people have celiac disease, but about 30% of those people aren't diagnosed. So we were always taught to think about it as a bit of an iceberg. So you might have sort of the top of this iceberg here with patients who definitely have diagnosed celiac disease, and then you might have this sort of gigantic portion in the middle of the iceberg that actually patients are undiagnosed. So they may be symptomatic, maybe not, but they may sort of start with some of the symptoms of celiac disease. And then there's a small proportion of patients as well who have what we call latent celiac disease. So they have the genetic predisposition, they have that sort of propensity to get celiac disease, but they haven't yet got that or any of the symptoms related to it. And interestingly, twice as many females as males are affected, as we know at the moment, but always changing. So what is gluten? And I always think of it, how can such a small thing be so problematic for so many people? But really, it's just, if this is a wheat grain here that you can see, hopefully, we have the outside of the wheat, and that's called the bran. So if you think of bran flakes or all bran, that's the outside of the wheat grain. Inside here you have the wheat germ, and then you have the little brushy bit on the top, if you can picture that growing in the fields. But it's in the endosperm that gluten sits, so it's really a part of the two proteins joined together. It's a gliadin protein and a glutenin protein, and they just sort of disperse throughout this endosperm, and so it's throughout the whole of the wheat grain, really. Now, in celiac disease, what happens when we eat this gluten? So in classical celiac disease, so this is a picture of the stomach and a small intestine and a large intestine here. And if we have a little bit of a closer look at the lining of the intestine here, we're thinking, well, what happens when we might ingest the gluten in somebody with celiac disease? So the gluten is absorbed, and you can see these little finger-like projections that are sort of line the full length of your intestine. And it's these little finger-like projections are called villi, and they absorb all of the nutrients from all of the foods that you eat. So in healthy gut, which is pictured on the left-hand side of this picture, they're all patent, lovely, plump, juicy, doing their job perfectly, and they take the nutrients straight to the bloodstream. Now, in celiac disease, what happens is gluten passes through the enterocyte, the cell that lines the intestine, and it clicks into sort of kicking off an immune reaction. So this can be in several ways. So it can be the macrophage, and these are just big immune molecules that come and sort of gobble up things when we've got an infection, but also T cells and B cells, and they produce something called antibodies and also cytokines. Cytokines are just molecules that sort of make inflammation, if you like, and antibodies, literally antibodies to gluten, then just go and almost attack the lining of the stomach. So you can see here on the right hand side that actually the villi, instead of being all nice and floaty and doing their job, they're actually all really patchy, degraded, they're really atrophic, as we use a medical term, and they just really can't do their job properly. So you often, instead of absorbing all of the vitamins, minerals, protein and everything from your diet, you just can't do that very well when you've got undiagnosed celiac disease. So it's really, and this is where the symptoms come along. So you might have terrible diarrhea, you might have constipation, you might have fatigue, and we'll run through those in a little bit more detail. So in somebody with a really healthy gut that has no problem with celiac disease, all the villi are patent and they're all waving lovely. In somebody with really severe celiac disease, you may have no villi that are standing straight, and that's called villus atrophy. And when you are diagnosed with celiac disease, you often get this, what we call the March classification. So it runs from 0 right through to 3B, 3B being the worst and 0 being a normal healthy gut. So when they take the little biopsy from the camera and they look at it under the microscope, they sort of measure the sort of the heights of the villi, and they can give you that grading. So what are the symptoms? And we mentioned that you might have some diarrhea, and that's definitely one of the more sort of commonly understood symptoms of celiac disease, but also constipation, and also obviously comes with diarrhea, you may then develop weight loss, but not always. And actually, especially in adult patients, you can actually be and not lose weight at all and actually put on weight. So it's definitely not a prerequisite to weight loss. And in the years gone by, that was always, if you were overweight, you definitely couldn't have celiac disease. And we definitely know now that that is not the case. A really telltale sign, and I was just reading something about this yesterday, saying actually it might be one of the first signs of celiac disease is multiple or just frequent chronic mouth ulcers, and just you never can quite get rid of mouth ulcers, and that can really be in children as well, right through to adults. Fatigue, just because you've not absorbed enough of the nutrition that you've got, and again that's linked with anemia, and that's when we're talking about loss of iron. So you might not have enough iron to really take the oxygen around your body, so you just feel tired all the time. Everything's a bit of a challenge to get through the day. Bloating, really common symptom that I think most people with celiac disease, right from the really severe children who present with celiac crisis, they would have abdominal bloating, right through to patients who are difficult to diagnose, maybe just mild symptoms. Bloating is probably a common thread through most patients. And then there's a little adjunct here, which is dermatitis herpetiformis, and that is the skin presentation of celiac disease, and not everybody gets that. But just because my other job, I am a bit of a dermatology dietitian, so I thought I'd add this on as a little bit of a close up there as to what dermatitis herpetiformis looks like. But it really is its own thing. So in dermatology, if somebody presents, and it can just be the only presentation, and I've seen this in really small children. In fact, last year I had a patient who was only 18 months old who presented with just a purely dermatitis herpetiformis rash, and that was all the only symptom, and he had obviously then diagnosis of celiac disease. So it takes a while. We would put a patient on a gluten-free diet for this, but it would take a little while to see an improvement, and that's really important, because if you give patients that information at the start, they don't lose hope basically as they go through. And this always relies on a skin biopsy to be taken. And interestingly, it usually presents symmetrically. So if you have it usually both elbows, both knees, and sometimes patients might get it on their scalp or their torso, but usually it sort of presents as if you would put a mirror down the body. You usually get it in equal measures on both sides. Increasingly, we understand now that celiac disease doesn't just present as those symptoms that I've just described, with sort of the diarrhea and the weight loss. Those classical symptoms are obviously really important. But what we now understand more and more about is actually patients with celiac disease often present with depression, anxiety, they often struggle with sleep, and lots of patients, children as well, will describe this brain fog. I've put in inverted commas, but almost like the best way to describe is everything's a little bit fuzzy, a little bit difficult to get through. So children at school may struggle with a little bit with learning, they might struggle with their concentration. All of those things might be related to their celiac disease. They might have poor appetite. If you're a young child, particularly, every time you eat, you get a tummy ache. Every time you eat, you get any of these symptoms that I've just described. There's enough for anybody to be put off eating. So often children become aversive, may only eat a very small number of foods, for example. A neurological presentation, something I'm really interested in, and I think this is the fantastic work that goes on in Sheffield at the institute there with Dr. Hajbaslu, I think is really worth an investigation for a little bit more information if anyone's interested there. And really that's looking at symptoms such as ataxia and peripheral neuropathy, and all relating back to celiac disease. Now, interestingly as well, we know that people with celiac disease tend to also have a sort of a commonality with other conditions, should I say. So people may have a higher incidence of diabetes, so they might have type 1 diabetes and celiac disease, and often you might see families with one sibling that's got celiac disease, one sibling that's got diabetes, and the two are very commonly closely linked. And usually most patients that have type 1 diabetes would, as a common practice, have a celiac screen. NICE guidelines also recommends that we test for celiac disease for Down syndrome, Turner syndrome, and anything related to thyroid disease at any age, just because, again, these autoimmune conditions and some of the syndromic conditions to have the higher proportion of patients will have this link to celiac disease. If left untreated, celiac disease can then also have these secondary conditions. So things like infertility, osteoporosis, and actually left untreated for long enough, you then have an end risk of actually developing lymphoma and small bowel cancer. So it's really, really important to if you think you might have celiac disease, to actually go and get this checked out and tested and made sure that these risks are reduced. We know, for example, once you're on a gluten-free diet for about 3 to 5 years, that actually the risk of developing all of those things reduces to normal. So the diet really is the main treatment for this condition. And there are a few other conditions. I've also written on there lactose intolerance, and often just prior to being diagnosed with celiac disease, as you remember the little villi that get a bit battered down when you eat gluten, right at the top of those villi, or right in the minutiae of the structure of the villi, is where you digest your lactose that you get in milk and breast milk and cow's milk. So actually, if they're all battered down, you just don't produce that enzyme in enough quantity to actually digest and tolerate lactose. So often you might find patients prior to diagnosis or just at diagnosis also can't tolerate lactose. Usually that would improve on a gluten-free diet, and it's really important to then sort of introduce lactose again, just to make sure that they're not excluding something unnecessarily. Now, I've popped a couple of interesting papers on here, and it's just to really highlight the differences between adult and pediatric presentations of celiac disease. Now, I'm a pediatric dietitian, so that's my main interest. But interestingly, and I just wanted to highlight this for you, was actually how the presentations differ between adults and children. So in children, looking back over the data, we can see that actually most pediatric patients are diagnosed with the really severe, faltering growth, sort of really abdominal bloating, may even be admitted with celiac crisis. And I've looked after patients, actually one patient had to go to ICU with celiac crisis. So patients with the pediatric population tend to present in that way. Patients in the adult population that potentially have had celiac disease for a lot longer, maybe not quite such a severe reaction, but nonetheless causing the damage as they've got older. So we tend to see that in adults, it's slightly different to the presentation in pediatrics. But I do think, as time goes on, I think we'll see that actually potentially there are more children that have celiac disease who just actually as awareness grows, as testing gets better, and we can understand maybe just screening more types of patients, more groups of patients, I think this picture might change. I've also put on here about transition. So really key is when you've had a patient diagnosed as a child, taking them through transition to adulthood. And I work in a children's hospital, so it's really pertinent to me to make sure that actually patients that go on then to adult services for whatever their condition, they get the support that they need at that time. As you can imagine, you've got a young teenager, they want to be the same as everyone else. There's peer pressures, there's financial pressures potentially at university, for example. You've got actually responsibilities for your own shopping, your own food buying, and maybe you haven't had that before. So really it's a key time to make sure that patients have the support and the planning that goes into that to make sure that they're capable and able to get through that period safely. And often it's a time when actually teenagers rebel against it and sort of relapse on the diet. So it's just a really important time. And there's a really brilliant paper, if anyone's interested in that, in a little bit more detail about sort of how to take patients through transition from childhood to adulthood. And there's actually it's called the Prague Consensus Report, and it just takes you through what steps should be taken in that process to make sure that patients are equipped for that change. So how do we diagnose celiac disease? So, talking about diagnosis is the most important thing is how much and how long do you have gluten in your diet for before testing? And this is crucial. If you haven't got gluten in your diet and you go for an antibody test or a biopsy test, of course, all of that damage that's been done, all those antibodies that's made against gluten won't be there. So you'll actually potentially have like what you call a false negative. So you'd have a biopsy that looks kind of normal, not any damage enough to qualify for celiac disease. But actually, it's because you've just been on a gluten-free diet. So it's really important that gluten's in the diet for at least, well, the official line is 1 meal every day, but I would say at least 2 would be good to really make sure there's enough gluten in there for 6 full weeks before having any testing. And this can be really tough. This can, especially if you've taken gluten out of your diet and then you have to put it back in again, it's really tough. And actually for some children have the difficulty getting their head around, oh, now I can eat normal bread again, now I can't. It's really a tough time, and having a dietitian maybe support you at that time can be really helpful. So looking at blood tests or serology, what do we test for? So usually we have these antibodies, sort of as first line antibodies, and they're the tissue transglutaminase antibodies, and they're related to IgA, which is immunoglobulin. So it's always really important, as well as checking for that gluten IgA TTG, we also check for the total IgA. There is a small proportion of the population just don't have IgA. They're IgA deficient. They wouldn't really know about it. It doesn't cause too many problems, but then they just won't have this antibody. Doesn't necessarily mean they've not got celiac disease. So it's always important that you have both of those measured at the same time. If you have got a deficiency in IgA, then there are some IgG antibodies that you can actually test for as well. So it's just important to have that there as the first line. There are other antibodies. There's the anti-endomysial antibodies and also these anti-deaminated gliadin peptide antibodies. And again, I'll go through sort of what order you would test those in, if that's helpful. We also know more recently that actually there are many types of TTG. So traditionally we check for this TTG2, which is the one that's like an initial screen. But we also know now that potentially there are quite a few other TTGs actually, so these antibodies against gluten. We know that TTG3, for example, is probably responsible for dermatitis herpetiformis. So maybe making sure that even if a patient was TTG2 negative, potentially they may have antibodies to these other gluten antibodies. The TTG6 is the one that's we think is related to neurological symptoms. And again, there are patients who have neurological symptoms to gluten who just have TTG6 antibodies and don't have TTG2. So they wouldn't necessarily have the little villi damage, but they might have damage to their nerves. And that's a slightly different sort of type of celiac disease, if you like, but nonetheless serious. So things have changed a little bit actually in the last couple of years. So it's worth sort of trying to keep up abreast of what's going on in terms of diagnosis. So for initial testing, as we said, you do the IgA and the TTG2 IgA. That's the most accurate, the most cost effective. It's actually quite cheap to do that. So you go to the GP and you get those done there. At that stage, you don't really need these EMAs or the DGP antibodies tested, not really essential at that stage, unless you're really symptomatic. So in children, if we have this TTG2 checked and the level is 10 times greater than the upper limit, so the upper limit's around 10, if it's 100, then you can really be sure that the levels are really high, and actually this is really indicative of a diagnosis of celiac disease. The next level would then be to check endomysial antibodies and a second blood test while still on gluten, and if that's positive as well, we can actually say actually that patient has celiac disease without having to have a biopsy. And that's a big change. In years gone by, this has been debated a lot, but actually really the data suggests that this is safe enough to do this. So in actually what's happened in adults, so in adults this wasn't the case, and actually all adult patients used to be sent through for biopsy with a camera test, but actually it's sort of COVID-19 has actually changed the guidance a little bit. And so if an adult is less than 55, has symptoms of celiac disease, has these TTG2 levels 10 times above the limit, has enough gluten in the diet, and has a positive EMA test, then they don't need to have the endoscopy. They have a diagnosis of celiac disease, and that's a big change. So it'd be interesting to see how that goes. Now, there will always be patients that fall outside of these criteria, and of course, that's what health professionals are there to guide you through that. So if you a patient, your child, whoever it might be, does, well, this kind of happened, but it didn't quite happen, they're just the discussions that you have with your gastroenterology team and your dietitian, and you make sure that actually the right tests are done and the right diet's put on at the right time. There is a genetic test called the HLA tissue typing, and actually it's really useful. Most people with celiac disease have the specific gene that gives them a predisposition for celiac disease. It doesn't always mean that they have celiac disease, so it's not used as a diagnostic measure, but if it is negative and the patient doesn't have that gene, then usually it means that actually celiac disease can be ruled out. So it's not always used, and it's not very common, especially more recently, but actually it can be used in certain circumstances if your team have sort of no other options. So I've just put a slide on here about non-celiac gluten sensitivity, and I could probably talk a whole hour on this, so I'll just speed through. But I think it's important to mention, because you might go through all of those tests that I've just described, and actually they're all negative, and you think, well, what then? Because actually I've found that when I go on a gluten-free diet, I feel a lot better. The symptoms that we've just gone through improve. What does this mean for me? Like, do I have celiac disease? Do I not? And actually we know more now about this non-celiac gluten sensitivity. And we also know that patients with this condition potentially have an innate immune reaction to gluten. So we don't quite know what it might be, as is the same with some types of allergy as well. So we know that potentially there's a select group of patients who test negative for the common antibodies for celiac disease, but are still having quite a severe, immediate, potentially innate immune reaction to gluten that can cause a variety of symptoms, and actually can be quite common to have neurological symptoms with this sort of reaction. There is a proportion of these patients as well who don't necessarily have anything related to an immune reaction or actually have anything related to celiac disease, but they may benefit from sort of a change in diet that actually just reduces some of the fermentable carbohydrates, and that's called the FODMAP diet. And so that was more linked to something like irritable bowel syndrome, and gluten, wheat can play a part in that. So it's really important to discuss that with your health team, just to make sure that you checked and diagnosis is ruled out before you go through with that, and then you can then see if changing and modifying your diet can help you. Now, if anyone wants more information, it's a few years old, but it's really brilliant. Professor Simon Murch, There's a lecture by him on the Celiac UK website. And if you can find it, if you sort of try and search for non-celiac gluten sensitivity, it comes up in the search bar, and you can watch his lecture, and it's really fascinating. Lots about insects and all sorts of things on there. So go and have a look at that. And also there's some really amazing research that's really centered for now, I think over 20, 30 years even, looking at these gluten-related disorders and particularly neuropathies in the Sheffield Institute of Gluten-Related Disorders. So have a look at their website. They also run conferences as well. So moving on to treatment of, we've got this diagnosis of celiac disease. What do? We take gluten out of the diet, and it's really important that we make sure that there is no gluten left in the diet. It cannot be one of those situations where you say, well, actually every now and again, it's okay if I have a little bit of gluten. Patients with celiac disease will, that damage we saw to the villi, even a small amount of gluten is enough to knock those villi down. And if you're doing that every week, every couple of weeks, you never just quite get the villi back to full health and have potentially your maximum nutritional absorption that you should have. So you'll just never be quite well. And all of those risk factors that we talked about will still persist. So to be on a gluten-free diet means 100% there's no gluten. We have to think about removing wheat, rye and barley and oats, and I'll chat about oats in a little bit more detail. I definitely am not going to try and say some of the pronunciation of these Latin words, but you can see here very nicely that wheat, barley and rye, they all come from the same species of grass. So you can see that there's rice, we've got oats, corn, sorghum, teff. All of the other grains that we get from the grass family don't have gluten in them, but wheat and barley and rye have the protein that we talked about, the avenine, the gliadin that we see in barley, wheat and rye. You can see oats are more closely related to wheat, barley and rye, but they are slightly different. So loads of foods are naturally gluten-free. And you can see here we have things like all the vegetables, fruits, potatoes, rice, quinoa, pulses, millet, meat, fish, eggs, tofu. So many foods are naturally gluten-free, of course, and a vast array. And if anybody's out there thinking, oh, I'm gluten-free and I don't know what to eat, there's nothing I can eat, really I would urge you to see a dietitian to help you to try and expand your intake, because there are some fantastic things that you can definitely eat. And of course, then there are the manufactured foods, and the foods processed to be gluten-free are required by law to be tested and to be less than 20 parts per million. So in the UK, we have in January 2012 now, I can't believe that seems so long ago, we now have these gluten-free labelling laws. So only foods that contain 20 parts per million or less can be labelled as gluten-free, and they have to be tested. So if it says gluten-free on the packet, you can be rest assured that it's been tested and it's less than 20 parts per million of gluten. So this is the sort of thing you would see on the free-from aisle, so you've got your bread, your crackers, flour, pasta, all those things, and it says gluten-free. They've all been tested to be less than 20 parts per million. The gluten-free label can also be seen on oat products. And the oats that you see in the free-from section in the supermarket are normal oats, but they've just not been milled in a factory that contains other wheat grains. So there's no contamination of wheat on the oats, but they are normal oats. But we call them gluten-free or pure or uncontaminated oats. So they're labeled gluten-free too. And then we have the very low gluten, and we don't really have any products in the UK that have this label. And this is products that have between 21 and 100 parts per million. So many years ago, 100 used to be our cutoff in the UK, but we dropped it to 20. So we don't see this in the UK anymore, this very low gluten. But in some other, if you did manage to get to another country at the moment, you might see this crop up. And in the USA, for example, some of their products have this sort of labelling. Interestingly, I was chatting to an Australian dietitian friend of mine who was telling me that actually in Australia, their cutoff is 3 parts per million. So I thought that is so interesting, and they don't allow oats at all. So really interesting. And again, probably something that we will see develop and evolve as time goes on. So as I said, oats are a little bit different. Oats don't have gliadin in the same way that wheat, barley and rye do, but they have something called avenine, and it's really structurally very similar to the the protein that's in wheat, rye and barley. So it's been really debated in the literature, and in the past I've done whole lectures on oats. You know, it's a really debated subject. And actually, when you look at those studies that have looked at, can celiacs have oats, can they not have oats, it's sort of unconclusive in many ways. So, and particularly the older studies, before we had these uncontaminated oats, so we just used normal oats, and of course they were contaminated with wheat. So any study that uses those oats from the old days before uncontaminated oats were available, you know, really we're not comparing like for like there. So we can't really look at those old studies. Now, there's a really amazing lecture, again, on Celiac UK website by Prof. London, and looking at this research on oats and sort of comparing, almost doing like a debate, should or shouldn't we include oats? So if you are interested in that, do have a look. And this really needs to be a patient-specific case. So, you know, and I'll just run through here. So in most patients with celiac disease, they can tolerate gluten-free oats, but not all patients can. So if a patient presented with a really severe symptoms, they had really a child with faltering growth, for example, we would always avoid gluten-free oats, all oats, and then, you know, we'd almost be waiting for that time when they're asymptomatic. We might have another blood test, is all of the TTG, all of the antibodies are normal. Now we might be able to introduce some oats and see how they go. And it depends. Some families really like to, and some families don't. But it's important to have that discussion with your dietitian. Now, there is a few studies, and I'm always a little bit wary. I have looked after patients who don't tolerate oats, so it can be an issue. And I think it's important for us to understand that some of the studies have shown that actually there are inflammatory changes with some patients that have gluten-free oats, and actually there are some of these more sort of microcellular level changes that you can see on biopsy, when actually the other symptoms of celiac disease aren't there, but these small micro changes are, that potentially could be still causing some symptoms. So it's really important to have this discussion, especially if you've been diagnosed with celiac disease and you still find that you're not 100% right. This is sort of chat to have with your dietitian. You know, could it be actually oats that are causing you to have some of those problems? Now, I've just bobbed on here Codex wheat starch. It's often something that I think probably causes a bit of confusion. So Codex wheat starch is something that you can see on, usually just on really specialist gluten-free products. I saw it the other day on a packet of pain au chocolat in Morrison's, so I thought, no, it's still there, it's still out there. And you'll see it's gluten-free all on the front of the packet, but when you look at the ingredients list, the first thing it says is Codex wheat starch, and you think, well, I'm a celiac, how do I eat this? And actually what has happened to that wheat starch is that it's been chemically altered to remove the gluten from that wheat grain. And so that the level is still less than 20 parts per million, so it's still okay to be labeled as gluten-free, but it's just got the other bits of the wheat grain in there, basically. So it just tastes a little bit more like wheat. And this is really safe for celiacs to have. I would always encourage anybody to use the Coeliac UK website for any help and support. And actually, they've got some really good apps that can help you. So they've got something called the Gluten-Free accreditation for caterers and venues. And some of you may have already used this like we do. And you often can go on the app, look to where you're going, you see restaurants, even at Great Ormond Street, I'm trying to get the catering department to have the GF accreditation. So it's really a stamp of approval to say that the people in that restaurant have been trained, they're audited, and you can all rest assured that that place is really, they know what gluten-free means. You don't have to almost have that conversation, you don't have to worry about it, which is really, really, game changer. So have a look at that. There's also different apps on there, sort of looking at suitable foods. There's the food free food checker, and that's almost like a replacement for what it was the old directory in paper format. So it's actually, you can have it in the supermarket with you. You see a product, is it gluten-free? I don't know, get my app out. You can scan it and actually it tells you there and then. So it's really handy to have. So I'm just going to run through a case study about a young lady who was aged 11 called Lucy. And she had a history of IgE mediated, which is immediate type allergy with like a swelling to wheat and also to grass and tree pollen, so hay fever. But she also had non-IgE mediated, so delayed type of allergy to cow's milk protein when she was a baby. But she's always had a bit of a problem with milk, but she can now tolerate some baked milk in her foods. She had eczema as well from infancy, so she has this sort of atopic picture as well, so sort of prone to allergies. Because of this wheat allergy, she'd always had a wheat-free diet, and at times there'd been suspicion that she might have had celiac disease. So she did have a celiac screen, which was negative. She had some HLA-DQ2 tissue typing, so that's the genetic predisposition for celiac disease, and that was positive. And actually her sibling and her mother and some other family members as well, when you went back through the family, also had a celiac disease diagnosis. So her current symptoms were bloating, she felt tired, and she actually wasn't able to attend school at this time. She had really bad constipation, passing a stool every about 3 weeks at some points in time. She tried all of the usual therapies, increasing fibre and all of those things, laxatives, Movicol, all of the usual things. And she'd also found that she had some numbness, particularly in her face, and that she couldn't really explain. And she had some sort of funny feelings in her toes and fingers. So at this stage, I think, well, what else would I need to ask at this time? So I'm thinking, well, I would ask, obviously diet history as a dietitian, that's my job. Am I thinking, is her diet nutritionally adequate? Does her diet contain any gluten at this time? She's wheat-free, but is there any other gluten in the diet at that time? Does she have enough fibre? She's got constipation, but do I need to try and work on that? Fluid as well, obviously important for constipation. And thinking about her wheat allergy, thinking, well, actually, she's probably avoided wheat most of her life. When she had her celiac screen, was she having enough gluten to sort of adequately be tested for celiac disease so that we could rule it out as negative? So thinking then about what the next steps would be. So there were sort of different ways that we could go here as a dietitian. So we're thinking, well, could we recheck celiac serology at this time? And we could maybe do these other antibodies, so do a bit more of a thorough screen for celiac disease. We could try and take full gluten out of the diet, really be strict about it and see if symptoms improved over time. We could recheck allergy tests. She had allergies as an infant as well, and she still has some allergy symptoms. So, maybe that's an updated allergy test, see where she's up to, skin prick testing, and potentially some IgE, so the allergy bloods. Maybe increase fibre again, and maybe think about multivitamin and minerals. Potentially, some of those symptoms could be potentially a deficiency in some vitamins and minerals. We could keep her on a wheat-free diet, but try and include rye, barley, and oat. Or should we try and take milk out? Maybe milk has been a bit of a problem, even though she's tolerating this baked milk. Is she tolerating the baked milk? So to tell you what happened, so this patient, Lucy, she didn't want to go on a gluten-free diet. She was so fed up, she wanted to just go straight to a really strict gluten-free diet. I beg your pardon, she didn't want to continue gluten, she wanted to go to a strict gluten-free diet. And despite me sort of encouraging her to keep gluten in the diet and have the test done, she was, I just don't want to do that, I just want to do this now. This was also during COVID, so getting to a GP, getting any of these blood tests was a little bit trickier. And actually we saw over the 6 months, so although she was wheat-free, we also removed rye, barley and oats. And actually over the 6 months that I reviewed her in that initial stage, what had improved was her constipation, her bloating, her fatigue. She still had some of the neuropathic symptoms, so the feeling of numbness in her face and her fingers, but actually it was better than it was. I'd started her on a multivitamin and mineral because I was a bit worried about her calcium intake. She didn't have a lot of milk because she avoided it, and also some iron. And actually, she just felt a lot better. She was able to go to school, which was a massive improvement in the quality of life for her. So we don't really know. Now, we've improved her quality of life. She's better. She said, I never want to eat gluten ever again. We're at that place. Actually, we don't really know what Lucy's diagnosis is. So she might have celiac disease. She potentially wasn't having enough gluten when she was first checked for her serology for celiac disease, but we don't really know because we didn't have those extra blood tests. Potentially, she might not have classical celiac disease, and actually she might have a non-celiac gluten sensitivity with this neuropathy as part of it as well. And really, as I said to her at that time, it's really up to her as a young lady getting older, making her own decisions. She could actually potentially re-challenge herself for those 6 weeks and go for testing and get the testing done, to just so that she understands her own body and what's happening to it. But really, that's her choice. And if she doesn't want to do that, I would support that too. So thank you so much. That is my talk on celiac disease, and really are happy to take any questions.
Natalie, thank you very much. We have a question already come through, and that is about whether you routinely recommend probiotics for patients with celiac disease.
Yes, I do actually, and I probably recommend probiotics to most children I see in my practice as a dietitian, unless they're immunocompromised in any way. But yeah, I think so, because sometimes patients may, it depends where they are on their journey to diagnosis. If they've been diagnosed and actually they're on the diet and they're improving, it will definitely help the microbiome. Equally, remember, if they've had this villus atrophy, really chronic malnutrition for some time, the diversity, so all of the different types of bacteria in their gut, will be really poor. So actually trying to build that up again once they're well is, I think, really important. So yeah, probiotic drops or anything like that.
And is there research on a specific strain, or that you use, or using a multiple strain or anything like that?
Yeah, multiple strain, not that I know of. But if anybody does know of anything, let me know. But no, not particularly with celiac disease.
So I've looked at it as well, and so I would also go for a multi-strain, and possibly something that also has a prebiotic in it.
Yeah.
But one needs to be careful to go for gluten-free probiotics. So there are some that are not gluten-free.
In fact, I saw one in the supermarket the other day that was a yogurt drink that had like grains added to it, and I thought, you can easily sort of think, oh, that looks good, that looks healthy, and actually it not be gluten free. So yeah. always worth a check.
Yeah, and I also sometimes play around a little bit, because sometimes you get additional bloating with one mix and then less bloating with another mix. Right. Yeah. Now, there are more questions coming in. How is non-celiac gluten sensitivity diagnosed? I'm going to ask that in two questions. So how is non-celiac gluten sensitivity diagnosed, as a first question?
Well, I would say the first line of that is definitely to rule out classical celiac disease. So if someone presents with symptoms, and they often patients may say, oh, we took gluten out and put it back in, we think this might be the food that's causing the problem. So if that is the case, really most important, you don't take gluten back out. Keep gluten in the diet, but then you go to the GP and you get that initial testing done. If you think, actually, I've still got symptoms, you can ask for a referral to the gastroenterologist, even if that initial, those first antibodies are negative. Some patients do have false negatives, and if a patient is very symptomatic, I've definitely known patients they've had negative antibodies, but they've had a biopsy. So if you're very symptomatic, you can go down that road. But if you've gone through all of those pathways and you found that actually all of the antibodies are negative, but you still think gluten's a problem, you've ruled out celiac disease, then I would then think about, well, is it non-gluten sensitivity, or is it irritable bowel syndrome? And at this moment in time, we don't really know how to differentiate between those two things. But equally, I think that I hope that will come in time. And I think that's with this the extra TTG antibodies that we're understanding now, and this innate immune system being able to look for that on biopsies, for example. So I think that will come in time. But the most important thing is, chat to a dietitian, or your GP, get a referral to a gastroenterologist.
It's a difficult one, because the non-celiac gluten sensitivity is really a diagnosis made by eliminating other diagnoses, but there's no specific tests outside of eliminating. And, once, as you said, you've gone through the pathway. And now comes to the question which you've kind of said, does the pathway go non-celiac gluten sensitivity, or do you go irritable bowel? Because the question is, do you recommend FODMAP or pure gluten avoidance?
And it's a really good question. And if you watch the presentation by Simon Murch on the Celiac UK, he'll really beautifully explain how some patients have this non-celiac gluten sensitivity, and some patients respond to the FODMAP diet. Now, the FODMAP diet doesn't necessarily cut out all the gluten grains. So and equally, sometimes on the FODMAP diet, you can sort of have a threshold for some of wheat. So it's not necessarily a total elimination of gluten, whereas with non-celiac gluten sensitivity, and the more I read about that, the more I understand that actually those patients are very sensitive to gluten. So the tiniest trace of gluten will cause symptoms in those patients usually. So if you can almost tease it out by dietary elimination, and so starting on FODMAP and then reintroducing foods, what happens, what are the symptoms, where is there a threshold, and then working it through with your dietitian.
Yeah, it's a question of kind of, and it's also the history, the symptoms that you've got, because I find often irritable bowel slightly different symptoms. So very good question. Next one. How does alcohol impact the gluten-free diet?
Alcohol?
Yes.
Oh, I love that. I never get asked that as a pediatric dietitian. And actually really interesting. So you would, obviously some alcoholic drinks have gluten in them. So beer is the main contender there. So definitely there are some alcoholic drinks that on a celiac cannot drink. So it impacts in some ways that you would have to modify what you enjoy drinking. There are many alcoholic drinks that are gluten-free. So that's, it's not that all alcohol is avoided.
But does it have a negative, outside of the contamination with gluten, where with beer, that would be prevalent, by the way, at the Oktoberfest, they started to now serve gluten-free beer as well. But does it have a negative? So if you've got celiac disease, drinking a gluten-free, alcohol, would that be contraindicated?
No, not that I've ever seen or read or experienced with any patients.
So next question, Natalie, it's really about the testing, and there are quite a couple of questions. So are negative TTGs reliable in children under 3 years of age?
That's a good question. Now, and again, this would really depend on, so if a patient came to me for advice and they had this history and it presented like celiac disease, I'm also thinking of the family history. Is there a family history of celiac disease? What were they weaned on? When did symptoms present? All of those things. And you can usually see a classical pattern in children under 3 if it is celiac disease. So particularly, for example, if there was literally no symptoms, and then when you introduce gluten-containing grains at weaning, you start to see the decline and the faltering growth. So there are things like that as a dietitian. I'd be little red flags that I'd be looking for, even if they had a negative TTG. I think usually though the specificity is quite good actually. So if the TTGs are positive in any way, it doesn't maybe necessarily get up to the 100 mark, but actually if they're positive and then you have the EMA that's positive, usually a child like that would go for a biopsy.
Yeah. And I suppose one question here that is a really important question is, you touched on and reinforced, which I totally understand, when you've symptoms and you eliminate, because many of our patients come to us already knowing they're really symptomatic. And this reintroduction is a really, really tricky part, because many of them don't want to go that pathway. Where does, the HLA DQ 2.5 or 8 or 2, where does that sit? Because could you say actually, because for some of them, the thought of introducing is just too much.
Yeah. And I think it's really tough to ask, especially a young child who's taking gluten out, and as a parent you've seen them improve dramatically, and then you say, actually for 2 meals every day for the next 6 weeks, which is a long time, can you put gluten back in? And actually many patients don't get to the 6 weeks. Or actually, if you ask them, well, did they have it every day? Well, not every day, and then that makes the testing a bit invalid, really. So it is really tough. And I would often advise my patients to possibly use things like wheat flour instead of actually going back to normal bread, just to help the child sort of not switch
cope
from
with it.
one to the other, so you're adding almost like as a medicinal amount of wheat, but not changing the diet from what you were on before, been known to them, so that is one way to do it. Now what is really exciting is that there is a really amazing piece of research that's been conducted, funded by Celiac UK, that is looking at changes, really tiny changes in the lining of the intestinal wall, that's looking for sort of other changes within the T cells that can show us actually that celiac disease is present
without reintroducing
the gluten. So
okay.
I'm really excited about that, because I think that will totally eliminate this. So if you think, oh, I've got a celiac disease, the GP can say to that family, take gluten out. We'll still put you on the, pathway for, diagnosis. You don't need to ever think of putting gluten back. I think that will be a total game changer.
So, Natalie, we've got a question. I think you've partly answered it, but I just wanted to touch on and to reassure it. It was just about the differences and whether there are differences coming back to non-celiac gluten sensitivity and irritable bowel syndrome. Because we spoke about symptoms of celiac disease, but are there symptom differences that you found with non-celiac gluten sensitivity and irritable bowel syndrome?
Yes, I think so. And I mean, it's difficult to say because everybody will be so different, and their amount of gluten they eat will be so different. But I think generally with irritable bowel syndrome, you might find that it would come and go a little bit. So other factors might influence irritable bowel syndrome. So you might be thinking, actually stress might influence it. You might think, actually, when I had my child had exams and it was so bad, the irritable bowel syndrome was so bad. So you might see this variation in irritable bowel syndrome. You obviously would get bloating, potentially constipation, diarrhea, all of those sort of GI problems that you might come across. But you wouldn't necessarily get maybe like the neuropathy symptoms, like the sort of the numbness and the feeling, the mouth ulcers, all of those things you wouldn't generally get with irritable bowel syndrome unless there was a nutritional deficiency, if the diet had been modified so much that there was a lack of one of the vitamins and minerals, for example. So yeah, I think there are probably some differences with non-celiac gluten sensitivity. Generally, if you have that, you just have it, and it doesn't go up and down. It just happens every time. And you might notice, well, actually, I had rice for a couple of days and I felt a bit better, and then I had some pasta and wheat and I felt worse. So you might get that kind of up and down, but generally it never goes in longer waves. So I think there are those subtle differences.
Yeah, I totally agree. And I think also what helps us, for irritable bowel disease, there is a criteria. The Rome criteria. Yes, I think that often helps us to kind of go through. But your dietary elimination, as you said already, also in my experience, non-celiac gluten sensitivity, it's really also trace amounts, small amounts really can lead to symptoms. Yeah. We're going to end up, really with some very practical questions, and that's about this cross-contamination. That's very, so you make a very good case for restaurants and all of those, but I think, it would be great to have everybody, but that's not the reality. So especially, when you're starting to go out and, so practical question, for example, if you've got a couple of friends, and like many people, you might have a restaurant that has got gluten-free bread, but you've got one little oil and one little, vinegar to kind of dab in. Is it to that sense that you say, actually, no, you have to have your separate oil? Give us some guidelines on cross-contamination that is practical.
And the answer to that is absolutely yes, is the answer. So particularly, I think it's difficult in somebody who doesn't have very extreme symptoms and has been diagnosed with celiac disease, because you get that with the teenagers, well, like a little bit, I don't tend to get any symptoms. But actually what you must remember is that you might think actually you're okay, but you just don't, that immune response is happening to those villi in your intestine or the nerves or whatever it is that's being damaged. So even though you might not feel a symptom, even that tiny bit of can cause that reaction to happen. So it's really important to avoid all contamination. So I would be advising separate toasters if you've got space for that. If you haven't got space, buy the little like I call them toaster pockets, like a little sort of hot proof little pocket that goes in the toaster. And I would take that with you when you go to like a hotel, anywhere that you think, actually, or someone's house, for breakfast. Actually, I'm going to take my little toaster pocket with me, and I know then I can have some toast, or take your bread with you, for example. Separate margarines, for example. So even that, if you take the margarine, spread it on normal bread, put it back in, spread it on the gluten, that sort of level of gluten contamination can cause a damage to somebody with celiac disease. So different margarines. We can get some really nice stickers that you have sort of for children. I often recommend these, so you get little sort of animals that say gluten-free, so you can stamp a sticker on the margarine that's gluten-free. But yes, essentially all contamination needs to go. So different spoons, if you're making something normal pasta, gluten-free pasta, different spoons to serve those up to that extent.
And as a final question, I often get asked saying, because, Natalie, the reality is you can't control everything. You can be as good as you are, and that works for all aspects of allergies. But let's say you've gone to a restaurant, you've been really good, but, they fried your fish in the same oil as, although you've got gluten-free flour on it, but it's in the same oil. That one exposure, is that damaging? Does that have a long-term damaging effect?
In the answer is yes and no. So if you went and had that fish, and you may not even know that happened, and that some restaurants tell you that they're gluten-free and that they understand it all, and actually they didn't quite. I once in a restaurant, someone told me that if you cooked something to a really high temperature, it killed the gluten, and I thought, oh my gosh, that is just so wrong. So get a feel and really discuss that with the restaurant before you go in there. But yes, the answer being that if you had that contaminated food, that immune reaction would occur wherever it's occurring in your body, in the intestine, in the nerves, in the brain, whatever it is that's happening to you will happen. Now, effectively, that will then cause damage, and it will potentially cause some symptoms. But if you then go back to strictly gluten-free, the damage is repaired. And we saw there that actually we know 3 to 5 years on a gluten-free diet, you're classed as a normal person if you stick to that diet lifelong. So that damage can be reversed, and it isn't often permanent. And what we do know about gluten neuropathies is that, unfortunately, if you're diagnosed very late in life, actually the damage that the gluten can have to your nerves is irreparable. The nerves are a little bit harder to repair than lining of the intestine, but it's not to say that patients can't improve, but they just can't potentially. Someone with gluten ataxia, for example, may never quite get.
But I think that is a really important message, because I think the what if, because you have those that kind of say, but you know what, I actually don't have the symptoms, and I see it especially in my adolescents. I don't have the symptoms, but actually it's this small cellular, the nerve damage, and that can have a long-term impact.
Yeah, for sure.
Okay. Yeah. But I think your message at the end is really important. There's so much you can do. It is, however, a lifelong condition that you need to stick to. But I think the message is really positive in terms of the alternative and things that we have. So thank you very much, Natalie. And thank you also for our attendees. Both me and Natalie, you can Google us, you'll find us. You could, when you registered for this, you'll have an email there as well. So you can always send us questions through. We've answered all of the questions that came through, but if there's something that you felt you could not ask tonight, do